Hello everyone and welcome to my channel. We are starting our next unit, that is nephrology. We will be discussing the important topics of nephrology. These are acute kidney injury, chronic kidney injury, post-streptococcal glomerulonephritis, nephrotic syndrome, and UTI. Starting from the first topic, that is acute kidney injury, which is the most important topic of nephrology. We are having a scenario that there is a 20 years old male, soft tissue extensive injury, bitten by dacoits and presented with generalized aches, oliguria, and dark color urine. On examination, BP is 160 by 100 and periorbital puffness and edema feet is positive. Another scenario is that there is a 45-year-old man, 3 days history of severe gastroenteritis. Since morning, he is passing scanty urine and increasingly become restless. On examination, he is dehydrated and having acidotic breathing. Another scenario is that there is a 30 years old athlete having severe pain in both lower limbs and decreased urinary output after prolonged race. Last 12 hours passed 200 ml of smoky color urine. On examination, BP is 150 by 100. Periorbital puffness is present. So what is the diagnosis, the causes, the investigations, management, pathology, and complications? The definition of acute kidney injury is that it is abrupt, that is decrease 48 hours, and increase in creatinine equal to 0.3 mg per dl, or abrupt, that is less than 48 hours, increase in creatinine of greater than or equal to 50%, or urine output of less than 0.5 ml per kg per hour for greater than 6 hours. The type of acute kidney injuries are pre-renal failure, intrinsic renal failure, and post-renal failure. The differential diagnosis of acute kidney injury are severe diarrhea, that is hypovolemia in hours or days, then blood loss and renal artery stenosis, then congestive cardiac failure, nephrotic syndrome, severe dehydration, post-streptococcal glomerulonephritis, protein dosing nephropathy, and acute nephritic syndrome. The clinical features of acute kidney injury are tachypnea, decreased BP, vomiting or nausea, dry skin, JVP is decreased, sunken eyes, altered mental consciousness, no urine pass, edema, and vomiting. The investigations for acute kidney injury are blood CP, that is leukocytosis is present due to infection, HP is decreased due to blood loss due to trauma, and thrombocytopenia is present due to blood loss. The electrolyte or osmolality, the sodium is increased, calcium is decreased in AKI, potassium is increased, and phosphate is increased in AKI. It is the electrolyte or osmolality is defected in all pre-renal, renal, and post-renal cases. The blood urea or creatinine increase because not excreted in case of acute kidney injury. Urinalysis, that is urinary sodium, is decreased in case of pre-renal cause. Normal sodium is 20 milliequal per liter. Less than 10 is equal to pre-renal due to decreased blood flow, and greater than 20 then renal cause, that is blood flow normal due to kidney. Then increased proteinuria, that is glomerular defect and sodium not conserved. Then hematuria, that is kidney injury, stone or obstruction or trach injury. Then urine microscopy is done, which is red cells renal cause, pus cells renal cause, and uric acid is due to gout, etc. Chest X-ray is done for pulmonary edema. Blood culture is done for infectious suspicious, and ABGs are done for states of acidity or basic levels, and plain X-ray is done for kidney size and kidney stones. Abdominal ultrasound is done for kidney size and kidney stones. Intravenous pyelogram is done. Dye is injected and structural defects are found. Then ECG is done, which effect of all metabolic processes on heart, and serology is done for HIV and hepatitis virus. CT scan is done for structural details, and renal biopsy is done for definitive diagnosis. Now, the management of acute kidney injury is hemodynamic status assessment, that is airway, breathing, ventilation, fluid infusion, hypovolemia, ringer lactate, isotonic, and diuretics, that is increased fluids. Then hyperkalemia, and acidosis is found, and it is treated. The increased potassium, for increased potassium, intravenous calcium gluconate is given, which stabilize the membrane of cardiac muscle and decrease the chance of arrhythmia. For glucose and insulin are given. Glucose secrete insulin along with glucose transport potassium inside the cells. Beta blockers are given, transport potassium inside the cell. Intravenous sodium bicarbonates are given for hyperkalemia and acidosis. For cardiopulmonary complication, ventilation is done. Diuretics and furosemides are given for decreased pulmonary edema, excrete. And for electrolyte disturbances, hypertonic saline are given. For dietary measures, fluid restriction and potassium restriction is done. Infection screening is done. Medications are given to avoid medicines that cause renal toxicity, for example, NSAIDs, to relieve obstruction. These are the management options. Now, the complications of the acute kidney injury are fluid overload, hyponatremia, hyperkalemia, infections, metabolic acidosis, malnutrition, anemia, and bleeding disorders. So, we have discussed the first topic, that is acute kidney injury, the scenario. Then we discuss the definition. Then we discuss the types, the differential diagnosis, the clinical features. Then we discuss the investigation options, which are blood CP, electrolyte or osmolality, blood urea or creatinine, urinalysis, urine microscopy, chest X-ray, blood culture, ABG, plain X-ray, abdominal ultrasound, intravenous pyelogram, ECG, serology, renal CT scan, and renal biopsy. The management options for acute kidney injury are hemodynamic status assessment, hyperkalemia or acidosis, for increased potassium, for increased glucose and insulin. Beta blockers are given. Intravenous sodium bicarbonate for cardiopulmonary complication, it is corrected. Electrolyte disturbance is corrected. Dietary measures are corrected. Infection screening is done. Medications are given. Obstruction is relieved. Then the complications are discussed. Now coming towards the next topic, that is chronic renal failure with renal dystrophy. We are having a scenario that there is a 45-year female, long-standing history of analgesia, abuse, history of generalized aches and pains, difficulty in walking. On investigation, low serum calcium, raised level of serum phosphate and serum alkaline phosphate, blood urea level 120 mg per dl and serum creatinine 5.2 mg per dl. FBC show normocytic normochromic anemia. So what is the diagnosis, the investigation, the treatment, and the counseling of the patient? The definition of chronic renal failure is that it is irreversible deterioration in renal function which results from a diminished mass of excretory, metabolic, and endocrine function of the kidney, which leads to development of clinical syndrome of the uremia. The clinical features are slowly developing, diagnosed accidentally, and swelling, anemia, tachycardia, breathlessness, decreased HB, anemia, and pruritus is present. The investigation options for chronic renal failure are AKI, that is assessed for acute kidney injury, history taking, and past reports are checked. Urea creatinine, that is slowly raised in chronic kidney disease. Fluid volume, that is anemia, not usually occur in acute kidney injury. Investigation for possible causes, for example, diabetes and hypertension. Urinalysis is done for quantity of protein. If severe sudden proteinuria, then renal biopsy is done. For electrolytes, increased potassium and decreased sodium, metabolic acidosis in case of chronic kidney disease. Decreased calcium and phosphate and parathyroid hormone, hypocalcemia, hyperphosphatemia in chronic kidney disease. Then albumin is checked, hypoether excretion, urine or is not making by body liver. Then blood CP is done for decreased HB in CKD, serum ferritin and vitamin B12 and folate levels to find secondary causes. Then lipids, glucose and HbA1c are checked. For the diabetes mellitus risk of cardiac disease, renal ultrasound is done for congenital anomaly or stone, etc. Hepatitis and HIV serology is done before doing the surgery, and other investigations are done. So these are the investigation options. Now the treatment options for the chronic kidney disease are, first of all, we have do the monitoring, that is at stage 1 and 2 after 6 months, and stage 2 and 3 and 4 after 3 months. The general measures are smoking cessation, moderate protein restriction, low sodium if hypertension, salt or water is decreased, restrict potassium if oliguria, restrict phosphate and magnesium, and dairy, eggs and meats. Okay, the management of complications are, if it is fluid and electrolyte balance and hyperkalemia is corrected by diet restriction and diuretics, and sodium overload by salt restriction and loop diuretics. Acid base balance is corrected. Renal bone diseases is corrected. For anemia, good diet, iron injections and recombinant erythropoietin is used. For hypertension, antidiuretics and loop diuretics and salt restriction is used. For infection, antibiotic therapy is given. For bleeding, dialysis is done. For GIT, bleed Ryzik is given, and for CCF, furosemide, AC inhibitors and digoxin is used. The indication for dialysis are uremic symptoms such as pericarditis, encephalopathy, seizures or coagulopathy, fluid overload, unresponsive to diuresis, severe metabolic acidosis, serum creatinine about 10 mg per dl and urea 200 mg per dl, and then transplant is done. Okay, the counseling for chronic kidney disease patient is that introduce and explain the disease, reassure the patient, encourage him to ask questions regarding his disease, tell him to reduce salt and excessive water intake, advise him a diet low in proteins, potassium, phosphorus and magnesium, tell him treatment options and encourage him to follow it, show empathy and say thanks. Okay, so we have discussed the topic chronic renal failure with renal dystrophy. We are having a scenario, then we discuss the definition, then the clinical features, and the investigation options, which are AKI, urine, urea, creatinine, fluid volume, investigation, urinalysis, electrolytes, and decreased calcium phosphates and parathyroid hormones, and albumin, then blood CP, then lipids, glucose, and HbA1c is done, then renal ultrasonography is done, then hepatitis, HIV, serology is checked, then others are done. Okay, the management options for chronic kidney disease are monitoring, then general measures, then the management of the complication, that is fluid and electrolyte balance, acid base balance, renal bone disease, anemia, hypertension, infections, bleeding, GIT bleed, and CCA. The indications for dialysis, then the renal transplant, and then the counseling. Now coming towards the next topic, that is post-streptococcal glomerulonephritis. We are having a scenario that there is a 12-year-old boy having headache, increasing in leg swelling, decreasing urinary output 2 weeks after discharge of air. Then on examination, he has BP 140 per 100 mm of Hg and periorbital swelling. Another scenario is that there is a 15-year-old boy having headache, increasing leg swelling, and decreased urinary output 2 weeks after a discharge of air. On examination, BP is 140 by 100 mm of Hg with periorbital swelling. Another scenario is that there is a 15-year-old male patient presented with history of having fever and pharyngitis. 2 weeks later, developed swelling around eyes. His urine was cola-colored urine output got decreased, and pulse is 80 per minute. Edema of feet present, and BP is 160 by 100 mm of Hg. So the definition of post-streptococcal glomerulonephritis is that it is most common type of post-infectious glomerulonephritis. There will be history of infection either in air or in throat or else air. Okay, so the clinical features are occurs 1 to 4 weeks after sore throat and caused by group A beta hemolytic streptococci, that is Streptococcus pyogenes. The investigations options for post-streptococcal glomerulonephritis are urinary, RBC, cast, and hematuria, proteinuria. Then SO titer is done. Serum complement system is checked, that is C3 and C4 level. Serum urea and electrolyte and creatinine are elevated. Blood culture is done. Renal biopsy is done, which is not used routinely. Light microscopy is done. Electron microscopy is done for subepithelial humps, and fluorescence microscopy, that is glandular appearance. The complications of PSGN is acute renal failure, acute heart failure, UTI, hypertensive encephalopathy. The causes of hematuria are UTI, pyelonephritis, enlarged prostate, kidney injury, kidney stone, and cystitis. The prognosis in children is excellent. Oliguria improves within a week. A small number of adults may develop hypertension and renal impairment. So we have discussed the topic PSGN, which is a post-infection kidney disease, and then we discussed the clinical features, then the investigation options, which are urinary, ASO titer, serum complement, serum urea and creatinine, blood culture, renal biopsy, light microscopy, electron microscopy, and fluorescence microscopy is done. The complications are discussed, then the causes of hematuria, and then we discuss the prognosis. Now coming towards the main topic of the nephrology, that is nephrotic syndrome. We are having a scenario that there is a 50-year-old male admitted with swelling of feet and breathlessness from the last 3 weeks. He says he gets this swelling off and on from last 2 years and using diuretic for it. Known patient of rheumatoid arthritis on treatment from last 20 years. On examination, he is anemic with periorbital and pedal edema. Chest examination revealed absent breath sounds, and at lung basis urinary shows protein positive, pus cells 2/3, and no RBCs. So what is the diagnosis, investigation, and complications and treatment? The causes of nephrotic syndrome are glomerular diseases and systemic diseases. In systemic diseases, we are having diabetes mellitus, amyloidosis, SLE, cancer, and injections of the drugs. The clinical features of nephrotic syndrome are edema, butterfly rash due to SLE, diabetes mellitus, nephropathy, infection, and frothy urine. The investigation options for nephrotic syndrome are urinary, that is proteins are present 24, or urinary protein that is greater than 3.5 gram means having proteinuria, serum albumin level, and ESR, which is raised infection, blood sugar to exclude diabetes, serology, hepatitis B, C, and liver or jaundice sign. Chest X-ray shows malignancy, TB test to exclude TB, and ultrasound abdomen is done for kidneys. ASO titer is done for post-infectious glomerulonephritis, common in children, and renal biopsy is the end option, which is shows the definitive diagnosis. And now coming towards the treatment options, which are diet, that is decreased salt diet. In diet, moderate protein restrictions and water. Diuretics are given, that is furosemide for edema. HMG coenzyme A reductase inhibitor to treat such as treat hyperlipidemia with statins such as ervostatin, maintain BP and fluid volume, and the specific treatment is for membranous glomerulonephritis 5th and 6th decade. Immunosuppression therapy is provided according to the amount of proteinuria. Prednisolone and cytotoxic drugs are used, that is azathioprine, cyclophosphamide, for 6 months. The complications of nephrotic syndrome are protein malnutrition, hypercoagulability, that is due to increased clotting factors, and sepsis and blood loss and volume. So we have discussed the topic nephrotic syndrome. Its scenario that there is a 50-year-old male who is admitted with swelling of feet and breathlessness from the last 3 weeks. He says he gets this swelling off and on from the last 2 years and using diuretics for it. Non-patient of rheumatoid arthritis. On treatment from last 20 years. On examination, he is anemic with periorbital pedal edema, and chest examination revealed absent breath sounds at lung basis. So the diagnosis is nephrotic syndrome. Now coming towards the next topic, which is UTI, that is urinary tract infection, also known as acute pyelonephritis. We are having a scenario that there is a patient, 20 years old married female, develop high grade fever with chills for 5 days of duration, and she is complaining of pain in the flanks. On examination, temperature is 102 degree and pulse is 110 per minute. She is standard at renal angles and no visceromegally. Urinary pus cells is 30, and there is no okay. The another scenario is that there is 2 days fever, chills, rigors, and dysuria present. On examination, temperature is 101 degree Fahrenheit and pulse is 110 per minute, and regular tenderness in the right loin. So the diagnosis, investigation, treatment, management, counseling, and complication. The clinical features of UTI is increased frequency of urine, pubic pain, burning micturition, increased urgency, frothy urine, and hematuria may be present. The differential diagnoses are UTI or acute pyelonephritis. UTI is cystitis or urethritis. Acute pyelonephritis is acute appendicitis, acute cholecystitis, and female ectopic pregnancy, rupture ovarian cyst, or sulfangitis. All of the following are the DDs of the UTI. The investigation options for UTI are urinary, urine culture, urine dipstick test, that is nitrates are present, usually nitrates present, leukocyte status increase, and glucose decrease. Urine microscopy is done, protein levels, hematuria, and WBCs are raised. Urine culture is done, bacteria might detect or not. CBC is done, which shows leukocytosis and raised ESR. RFTs are done, urea electrolyte and disturbance will urea and electrolytes will be disturbed. Blood culture is done for septicemia. Renal tract ultrasound or CT scan is done for obstruction. Pelvic examination is done and cystoscopy is done. Endoscope is passed in severe cases. The management options for UTI are general, that is temperature control with sponging, and then planting of fluids are given, and pyretics are given, and intravenous fluids are given. Monitor intake and output record, and pulse, BP, and temperature. The specific measurements are antibiotics, that is ciprofloxacin 500 mg, tabs and tab novidet 500 mg. Citro soda or Cranmax juice for dysuria can also be used. The first line in past was trimethoprim and nitrofurantine. Now first line treatment is quinolone, that is ciprofloxacin and novidet and ofloxacin. The second line treatment is coamoxiclav and amoxicillin. In pregnancy, penicillin and cephalosporins are used. Trimethoprim, sulfonamide, fluoroquinolones, and tetracyclines are contraindicated in pregnancy. Pyelonephritis, novidet, cephaloxime, and first line and gentamicin is the second line of treatment. UTI treatment for simple UTI is 3 days, and for severe UTI is 7 to 14 days. The complications of UTI are sepsis and shock, emphysematous pyelonephritis, pyonephrosis, that is abscess formation, and chronic pyelonephritis. The justification of diagnosis is that history of fever, rigors, chills, dysuria, pain, and tenderness will be present. Lab diagnosis shows leukocytosis, means infection, as well as increased neutrophils also indicate some sort of bacterial infection. Then counseling is done, that is introduce yourself, explain the disease, reassure the patient, tell him to take plenty of water and take special care of hygiene, especially genitals. Then explain treatment and complications of the disease. Ask him to take citralca or cranberry sachet for dysuria which is relieved, ask him to come for follow-up, or if not getting well with the medicines, then and then thanks the patient. So we have discussed the last topic of the nephrology, which is UTI, and which is very important topic. We discussed the scenario, the clinical features, and the differential diagnosis, which are UTI and acute pyelonephritis, and the investigation options, which are urinary, urine dipstick, urine microscopy, urine culture, CBC, RFTs, blood culture, renal tract ultrasound, pelvic examination, and cystoscopy. Then the management options, which are both the general and specific. Antibiotics are given first line in the past and now first line treatment and second line treatment, and then medications that are used in pregnancy. Then for pyelonephritis, then the complications of the UTI, then the justification of the diagnosis of the UTI, and then the counseling for the patient of the UTI. So we have covered the following topics in the this video. These are acute kidney injury, chronic kidney injury, post-streptococcal glomerulonephritis, nephrotic syndrome, and UTI. Thanks for watching.